Bismillahirrahmanirrahim. My name is Professor Brigadier Nuzhat Mushahid, and I'm a hematologist and by training a transfusion medicine specialist. I have served in armed forces, Pakistan Armed Forces, for the last 33 years, and I retired in 2019. After my retirement, I have set up a blood transfusion center in Rawalpindi, Islamabad area, and I am working for realization of my goal of making blood availability and safety viable for as many sectors as possible. I want to thank the organizers for inviting me this talk on hemovigilance in HemeCon 2022. The topic I have selected is a relatively new development in the science of blood transfusion. However, it forms the basis of many risk mitigation strategies and many of the patient safety initiatives, as well as donor safety. This remains very underdeveloped and rudimentary in our country. And the reason being, one of the reasons being lack of awareness. It is only possible to reap the fruit of this initiative once it is done at a very large scale and data is managed in such a way that it leads to tangible and objective solutions to some problem which can be widely implemented. So with this background, I want to embark upon bring the attention of the audience to this important initiatives, giving you a background, and especially the challenges that are among us in setting of a fragmented blood transfusion system. History of blood transfusion can be conveniently divided into two main eras. One of them we can label as pre-modern and modern era, and the watershed being the Second World War. The Second World War was also, as many other scientific developments ushered in, also the developments in transfusion medicine science also took place. There are many milestones that I have listed here. However, the most important of these is the aid crisis, because the way it shook the confidence of people in public health safety and mistrust of the governments finally led to a lot of attention by the states on this science of transfusion medicine. And a lot of developments took place, which included legislative reforms, reorganization of the modeling of the blood transfusion services. And finally, it was found that everybody realized that blood transfusion has inherent risk because it's it should be taken as an allogenic transplant, where it is fraught with biological risk because of the antigenic differences of the cellular component and immunological differences between the donor and the recipient. It is also capable of disease transmission due to various pathogens. Some are known and some are emerging. And there are additional some effects because of the way that blood has to be stored and manipulations and storage that take place, as well as inherent colloid properties. In addition, there are many medical errors, risk due to wrong decision, as well as administrative errors. So all of this this is unique to this specialty, which calls for a lot of deliberation on the way that it is dealt. So entire blood chain is prone to risk and danger, but it does not mean that we should undermine the fact that it remains a life-saving treatment, which forms the basis of development of many of the medical specialties. So we need to have a balanced look, but at the same time, we should also strive to reduce the risk, to minimize the risk in order to keep on reaping the benefit of such a useful therapy for which no alternative exists still. So because of this attention that I told you about with the AIDS epidemic, national and internationally, need was felt that this science should be practiced. It should be, it is very close to the way the industries work. So a very effective model of transfusion medicine service delivery in a country would be where the blood supply system is segregated from blood usage and utilization system. This would fall separately in a which are very recognized as a blood banking, while the clinical utilization is the responsibility, and looking at the effects on the recipient falls in the domain of hospital blood banks and clinical transfusion services. And there are many tools for that as well. It is since it's a huge undertaking for any country, so therefore the states are responsible for ensuring the safety and availability of the blood. And what they do is either the state is themselves take the responsibility of delivery of the service, as happens in the European country, or they can outsource and delegate the responsibility to a credible organizations and then strictly regulate the service, as it's seen in USA, where this is undertaken by American Red Cross. Internationally, because of the way the development has taken place, and there is a need for reform, and it has to be conducted, and this service has to establish in a framework which involves the legislations, regulations, and many directives and guidance are available both from international organization like WHO, as well as very national, many national and local guidelines. This is not an exhaustive list. If somebody wants to search for the international publications on that, these are open source and easily available. There is a great need for a data on predicting the transfusion risks, because this forms the basis of learning and looking at the safety, existing safety, and move on to aim of zero risk from blood transfusion. Maybe theoretically speaking, maybe each unit should be subjected to elaborate testing, but we know that this cannot be comprehensive enough, and neither it will be, and maybe it will lead to destruction of the units, and that is no longer practical. We can estimate, and there has been an attempt at estimating risk for from the characteristics of the donated units and the recipient population. And we have seen mathematical modeling which estimates the likelihood of a unit containing an infectious agent in order to estimate the risk of transfusion transmitted infections. We can look and think about prospective studies, but a huge number of observations would be needed at a larger scale, which is probably the resources cannot meet that need. Retrospective studies are again impossible, where data has been varied, not systematic and based on certain preset criteria. There has been, the events have been collected, recorded with different methods and definition. So all of these are quite imperfect models. The best way remains to be a practical method of assessment of risk would remain a prospective clinical case reporting. And this is the concept behind haemovigilance. And as defined by International Haemovigilance Network, the clinical case reporting in a way which is a set of surveillance procedures which cover whole of the transfusion chain, from collection of blood and its component to follow-up of its recipient, with the intention to collect and assess the information on unexpected or undesirable effects which result from therapeutic use of labile blood products, and the aim being to prevent their occurrence and recurrence. A haemovigilance system only comes into existence when the data for adverse transfusion reactions are collected through an organized network of reporting to a central office, where the data would be collated and analyzed and evaluated by experts who would recommend appropriate actions for enhancing the blood safety. So that would mean that, to broadly speaking, that would fall into 8 actions that has to be taken, and that is defining the risk from blood transfusion uniformly, then making observations of the adverse reactions or events from after blood transfusion, recording those systematically in a structured form, reporting of that, and that collection of data that after reporting is analyzed, and basis of analyzing, the recommendations are made, and those recommendations by experts are to be implemented, and after implementation they needs to be monitored. So these are the basic 8 steps that forms the basis of a system of hemovigilance. If you look at the hemovigilance history, that how it has evolved, started off in France, mandated by legislation in 1993. And later on, other countries joined in. Some of the countries have voluntary reporting systems, like in UK, and later they moved on to mandating that reporting system. Similarly, this evolved into firstly the national initiatives, and then it formed regional, and finally now international initiatives. So other countries have also progressed and taken this initiative for the same reasons. The hemovigilance organization and design models basically are because the way it is covered by legislation, whether it is the designs may be such that it calls for mandatory or voluntary reporting. It can be centralized or decentralized system, and it also depends upon the governance structure that hemovigilance system, which is built on in an individual country. So these are all the stakeholders in ensuring the governance of and setting up of the system. And this table just highlights the way there's a relationship between different authorities in a European model. So there's minor differences in the designs and organizations of hemovigilance models across countries. However, many of the countries who do have an institutionalized pharmacovigilance system beforehand, they have used many of those principles and applied them in hemovigilance system. So to start off, we defining would include these 3 domains. That is, the adverse events have related with the transfusion need to be defined uniformly and have a consensus on that. The adverse event severity that means the impact of those events on a patient, and also the imputability of the event. How strong is the causative link to the transfusion? So the terminologies that has been coined and described are adverse event, the incident, the near miss, and the adverse reaction. And adverse reactions are like the undesirable response or effect temporally associated with the administration of blood and blood component. It may be result of an incident or interaction between a recipient or a blood. So this slide just briefly shows you relationship between these 3 domains. Further, these adverse reactions are classified on which by the International Hemovigilance Network, and it is widely adopted, where this acute and delayed is differentiated based on the time. And then this is a convenient pathophysiological classification where the reactions are divided into immune-mediated and non-immune-mediated. The gravity and severity of the adverse events have been graded from 0 to 4, depending upon the seriousness of morbidity associated with the adverse reaction. of the recipient in the recipient. Imputability means establishing the relationship between the adverse event and the transfusion that happens in the recipient. Since the patients who are admitted are undergoing so many other interventions, so it is not always that the blood transfusion is responsible for many of them. So it is important to establish the causative relationship between the blood transfusion and the recipient. So the application of haemovigilance on production segment is one of the examples I have cited here, where the blood establishment would be testing the blood for TTIs and study of the bacterial contamination during production. And similarly, the transmission of prions have also been studied. And in donors, the documentation and reporting of the serious effects to the donor has also been documented and reported. So what this has resulted into is collation of the data has resulted into recommendation and has led to important safety initiatives and intervention like NAT screening for TTIs and bacterial screening for platelets prior to release, as well as initiatives like pathogen inactivation of the platelets and FFPs. It has also resulted in improved donor safety by different interventions and more attention to those adverse reactions of the donors through the haemovigilance programs. So international haemovigilance collaboration data of this scale has proved that blood has never been safer, which is never safer than what it is now. And they are at least in the developed countries. And many of these safety initiatives are because of the program's effective and successful haemovigilance program. Yes, haemovigilance has worked, and it is not merely exercise in data collection. It makes a difference, as is shown from the serious hazards of transfusion program, haemovigilance program in UK. The risk has, or adverse effects have definitely decreased after the introduction of this program. Now coming to our country, the fragmented blood transfusion system in country is delivered through varied stakeholders and sectors. And I've borrowed this slide from Dr. Sabha with thanks. And it just summarizes that all these sectors playing and delivering the blood transfusion service in the country is fraught with so many problems. Fortunately, the reforms took place with the help of a German government and started off in 2008. It met some setback after 18th Amendment because of delegation of the health responsibility to provinces. However, the progress did happen, and Safe Blood Transfusion Authority formulated the National Blood Policy and Strategic Framework was written down for 2014 to 20. Broadly speaking, this is a broad framework in the way the blood transfusion system has to be organized and countrywide. The responsibilities of different stakeholders, but the forefront at the level of the service delivery are the blood banks and blood centers who need to commit to the safety and efficacy and quality, as well as commitment to safety and efficacy and quality by the clinical services. This, of course, remains the much weaker as compared to some progress, tangible progress, and a significant progress made on this side. The final program is to construct total of 30 RBCs. So far, 11 has become operationalized and 10 are under construction. The real challenge, however, remains that the delivery of service successful service and in a public sector to run these RBCs and hospital blood banks successfully in order to ensure safety and availability and quality of blood products. Just a brief situation that has been reported, which is reported from Central Punjab Blood Transfusion Authority data shows as late as 2020 only less than 20% of the blood collected is tested with a standard of care ELISA and CLIA, while most of it still is being tested by rapid devices of variable sensitivity. So that is a situation from where we want to move on and have a well-organized transfusion system that can ensure safety. We have a lot of land to cover, obviously. Now I'll want to draw the attention of the audience to the legislative framework, and this is I'm starting off with the legislation, Punjab Blood Transfusion Authority Act 2016. This amply emphasizes the haemovigilance, and it provides a very good framework and basis and blueprint to make a progress if we have will to actually make a progress and realize the importance of it. So here, not only it has been defined, it also has explicitly stated the need for blood establishment computer software. And repeatedly, it alludes to mandatory donor and recipient haemovigilance. Similarly, it has probably mandated the haemovigilance, and punitive and coercive actions need to be taken, and this is covered in legislation. It does have a provision of regionalization and a wider engagement of many stakeholders if such a program is to exist and a system is to be established. In sense, again, there is a elaborate definition of haemovigilance. Events are also defined. Similarly, events and adverse reactions are amply defined, as well as, again, emphasis on blood establishment computer software and use of technology for the program of haemovigilance. I'm not going to read this legislation in detail because these are all open source and available on the internet, and somebody, if he's interested, they can download it and study it in detail with the viewpoint of knowing what is stated there for haemovigilance. Again, emphasis on the technology is there. Reporting, traceability, and requirement of uniformity of technology and blood establishment computer software is all there in the legislation. It also calls for the professionals and expert and professional societies for collaboration and elaboration and lobbying and advocacy. This is food for thought for our society, that how much we have actually utilized and used this very elaborate legislation to furthering the cause of transfusion safety in the country. I think we should capitalize on it, and that will go a long way in introducing risk mitigation strategies in our country as well. It has also alluded to formation of hospital transfusion committees, which are actually a mandatory tool for haemovigilance, and it is definitely suggested there. Similarly, the legislation in KPK also defines haemovigilance and notification system, reporting system. In fact, this is one of the best legislation that has defined the adverse transfusion reactions and gravity and severity of reactions, which is nearest to what the international definitions are. There's also explicit use of technology. In fact, the haemovigilance system or any other system of reporting and data collection cannot happen these days, especially of that scale, without use of technology and computer and information system. And the national strategic framework defines hemovigilance as one of the key business areas. And the progress, real, tangible, at the level of provinces and national level is yet to be realized. I would call, I've listed here the WHO action framework for advancement of universal access to safe, effective, and quality assured blood products, which was revised, and 6 stated objectives. What I've done is I've highlighted in green those areas which are where our country has made some significant progress. Gray is the gray text shows where we have yet to make a lot of progress, and it's just a preliminary thing that has been done. And finally, the red is area where absolutely no significant progress is seen and is made. For example, we have appropriately structured, well-coordinated and sustainably resourced national blood system. Regulatory capacity, yes, it has been enhanced, and whether it ensured quality and safety of blood is open-ended. Functioning, and yes, but efficient management of the blood services, again a gray area. Then the effective implementation of patient blood management to optimize transfusion practices, and effective surveillance, hemovigilance, and pharmacovigilance supported by comprehensive and accurate data collection system, partnership, collaboration, information exchange to achieve key priorities and jointly address challenges and emerging threats at global, regional, and national level. They all fall in the red zone, meaning thereby that it is hardly we have made any progress, and it is no surprise that all of these actually have a lot of calls for a lot of involvement of the clinical services. Now, setting up of a hemovigilance system would require a meticulous planning to address some critical issues, like the organizational setup with defined responsibility to implement the hemovigilance as a national program. We have to decide which adverse events are to be reported and what comprehensive reporting system we can put in place. Who shall be made responsible for reporting? What mechanism should be put in place for reporting? We have a consensus, uniform definition, dissemination of this uniform, and receiving that data in a standardized format. Whether we should, I don't think so that voluntary reporting is a way forward for our country, at least. Yes, non-punitive approach can be to mandatory reporting as well. Who would be the expert groups and committees for analyzing this data, creating awareness and training program for staff who will be participating in hemovigilance. And this all cannot happen without adequate financial resources. And all this is needed for implementation of corrective and preventive action at the grassroots, and knowing that those action has been taken place. In a fragmented transfusion system like ours, federal and provincial safe blood authorities need to steer the hemovigilance program in light of legislation that we have seen amply supports and mandates hemovigilance program. There should be a close coordination and communication with the Healthcare Commission for the ownership of hemovigilance program, and work for common vocabularies, rules, and strategies. Here we see a lot of gap because of lack of coordination and communication. The key initiative for formation of groups of experts from all of those sectors which are delivering the service should take place, and engage the professional societies. And in fact, the professional societies should be proactive in engaging the authorities to make regulatory rules and committees for implementation. And the foremost in a fragmented blood transfusion system, if one thing that can be done and that need is met and is implemented, probably would make a huge difference, and that is to introduce or mandate the use of information technology in blood banks of all levels, of all sectors, of all scales. Information management systems can be developed by for example, the Punjab has the capacity in the form of Punjab Information Technology Board. They can develop the system and make it available across the province, or they can recommend the existing ones based on compliance with the international compliance, for compliance with the international standards, as well as with the legislation, national legislation and standards. This is the key initiative. If it is taken, that can actually work within a fragmented transfusion system very well. And the authority needs to just focus on mandating the use of a standardized information technology system. Professional societies must also be proactive in prioritizing the hemovigilance, lobbying for rules and regulation, and form working committees, focus on education and training, and voluntary and accreditation standards, support and promote information management system. Obviously, we can't deny the importance of patient advocacy groups and involvement of the civil society. So in conclusion, all stakeholders in country should strive and contribute towards setting up an effective hemovigilance system, which will go a long way in ensuring patient safety and improve transfusion medicine practice in the country. Thank you very much.